Well, welcome.
Hey, thank you. It's nice to see you.
Thank you so much. I was just, let me reshare because it's possible that no one was hearing us at all. But I was welcoming everyone to Hernia Talk Live, which we have every Tuesday. And this week you are our guest, Dr. Heidi Miller at Maine Health, very talented minimally invasive surgeon. I have a lot of questions for her because I want to know more about her life, as well as the topic of today, which is going to be side hernias. You can follow her on Instagram at Shutter and Scalpel. She's got some pretty cool things to share about her life, both surgical and non-surgical. So welcome.
Hi, thanks.
Um, so you're currently in Maine right now?
Yeah, in Maine at 7:30, the sun's going down because we're so far on the East Coast. We're on the far end of the Eastern time zone, so we get early mornings and early nights.
Yeah, my friends just came from there. I think they were vacationing in Maine.
Uh,
Montauk, is that right?
oh, Montauk's in New York.
Montauk's in New York.
Yeah.
Where were they in Maine? Kennebunkport is where they were,
Oh, yeah,
in that
okay.
region.
Yeah, in southern Maine. Yeah, very nice.
Very nice.
Yeah.
When I was in elementary school, our principal went to Maine every summer.
Hmm.
That was like her thing. She had a house in Maine. Um, and the pictures that I got from my friends as they were vacationing, because they did Cape Cod, they did Nantucket, they did what's another town near Kennebunkport?
York is down there, Kennebunk, Kittery. I know the Portsmouth is in New Hampshire. They might have
Or
stopped through Portsmouth.
yeah, but they did mention Kennebunkport. Anyway, I was following them on Instagram. Like it's just so beautiful, that whole area.
It is beautiful. They call it vacation land, like because that's what everybody does, and they come here for
I
vacation in
mean,
the summer.
that's what they did.
Yeah. And a lot of the Mainers have camps. They call them camps. They're like cabins on a lake out
Yeah.
in rural Maine that they've had for generations. It's just a thing that people do. But I feel like people have some connection. Like my mom was a camp counselor for a summer when she was in college in Maine, and it was something she always talked about because I didn't grow up here. And so now she loves coming back to visit because it's like reliving her youth a little bit, which is so fun.
And you've been in Maine for how long now?
6 years. Actually, I think I bought my house 6 years ago today because
Wow.
yeah, so it's been a
Congrats.
while now.
Congrats.
Thanks.
And so you practice all sorts of minimally invasive surgery with, I know you have a special interest in hernias and abdominal wall reconstruction and so on. Maybe explain a little bit about what your practice is like.
Yeah, I my practice is interesting because I definitely have an advanced foregut practice, and then I have a complex hernia practice. And I work in a group of four surgeons. There's another hernia surgeon who really focuses more on outpatient. So he's a very high volume, but more kind of outpatient. He does a couple big things in the hospital.
Uh-huh.
And then two bariatric surgeons. One of them does bariatric and foregut, so we all cover each other. And my practice ranges from endoscopic, like POEM for achalasia. So I do
Yeah.
endoscopic interventional endoscopy to the big, like last Friday, I did a massive complex hernia with all the intestines on the side
Oh,
and
wow.
an 8 pound, no, a 13-pound paniculectomy on the same lady because she'd lost a ton of weight and was
Oh,
fabulous. So that's kind of my range. And it comes out of fellowship really, because when I did fellowship in Cleveland, I had Yuri Novitsky as my hernia guy, and I had Jeff Marks as my foregut and endoscopy person.
yes.
And Jeff always joked that our fellowship was funny because we did like the least invasive surgery and
Yes.
most invasive surgery,
Yes.
not a lot of in between. And that's what my practice is today. I do a lot of revisional foregut too, like redo hiatal hernias and redo Nissens and stuff.
It's funny you mentioned about the this humongous hernia that you fixed. Every time I'm at like our morbidity and mortality conference or chiming in during grand rounds, there's always a surgeon that kind of poo-poos us fixing these really complicated hernias because they assume it's fraught with complications and you know, the questions like, how much pain was the patient in and, how sick were they? Did they really need a hernia surgery? And they keep making like, um, was this a life-saving procedure? And I always make the comment like, yes, there are situations where we're saving a life with hernias, but most of what we do is improving quality of life.
Yeah.
And there's tons of evidence that shows that these massive hernias should be repaired because it really, like the risk benefit ratio, assuming the patient's healthy enough to undergo surgery,
Mhm.
is really massive. You really improve their quality of life.
Yeah, this lady's she's in her late 60s and she has some baseline mobility problems, so she walks with like hand canes. But I am 100% certain that with her hernia fixed and without a large Panelist to offset her balance, she'll be able to walk cane free.
Oh,
Like,
wow.
you know,
That's huge.
that's huge.
Yeah.
And then she had lost over 100 pounds. So to take 13 pounds of just skin, most of which her hernia was in anyways,
Yeah.
off will just help her. I mean, it helps everything from hygiene to mobility to personal satisfaction and confidence, That's
Yeah.
I know my family will say like that too. Oh, she's a surgeon. She's out saving lives. I'm like, I might not be saving lives, but I am changing lives. There's no doubt about that.
Absolutely. Yeah. And I feel some surgeons don't offer surgery because it's almost a fear that they're going to hurt the patient, not understanding the benefits, assuming the surgery is well done, the benefits for the patient. So today, well, we have our audience who's watching both on Facebook and on Zoom. I'll be monitoring any questions that come through. But I've never really spoken specifically about these side hernias. Everyone talks about belly button hernias, diastasis, incisional hernias. Um, we had a couple episodes specifically on parastomal hernia and flank hernia, but not enough to kind of talk about the difference between a side hernia versus the middle. And I feel that not enough, well, for sure, the patients probably don't understand why it's so different, like it's such a different animal. Uh,
Yeah.
but also, a lot of surgeons, I feel, don't really appreciate incisions to the side versus the middle and the risks of doing that sometimes in patients.
Yeah.
Yeah,
Yeah. It definitely adds some complication for both. Yeah.
yeah, absolutely. So, and we have some questions that have been already submitted ahead of time. I'll run through those. But it looks like we already have some questions submitted. Let's see what we have here. Um, Okay, so one of the questions proposed is the issue of peristomal hernias. We know that about a quarter to a third of peristomal hernia of stomas, so ileostomy, colostomy, urostomy probably resulted hernias.
Hmm.
You want to just let me know exactly, like, things have changed. It used to be that you would just switch it around, and then there was like we went back and forth about using mesh the first time to prevent hernias. Now we're kind of looks like we're being a bit more conservative, like only repair the ones that really bother people and don't address every single hernia. So, what has been your experience with peristomal hernias, which is hernias after you perform like a colostomy or ileostomy or urostomy?
Yeah, the peristomal hernias are a losing game. Like that's the really tough thing about them. I just had a CAT scan of a patient come through today. She was a lady I did a big abdominal reconstruction on with because she had it was all peristomal hernia, but loss of domain, like everything out in the hernia from this.
Yeah,
And she had had rectal cancer, so it's an end colostomy, so it can't be
permanent.
reversed, right? It's permanent.
Okay.
And she lost weight and we got her optimized and I did this beautiful abdominal reconstruction, but she has her stoma. And what I tell patients when you make a stoma, you make a hernia. Because the definition of a hernia is bowel poking out through a hole in the abdominal wall, right? And
Yeah,
that's exactly what a stoma is. So we're basically making a purposeful hernia when we're making a stoma. And so it's kind of a losing game. And we've
yeah,
try things like how tight do you make the hole? Where do you put mesh in at the beginning? And where do you put the stoma and what kind of stoma? And there's rates up to 70% even in some
Yeah.
studies that what people will get parastomal hernias. So I think that's for the first thing to understand is like it's just the nature of the disease and the problem. And if you don't get one, you're lucky. That's kind of the starting point. And
Okay.
so that lady actually, I she came back with a recurrence, and I did a robotic repair after her big abdominal wall repair with
Oh,
a sugar baker. So I kind of call it a mesh hammock, right? And then yeah, and then she just was back in my office a couple of weeks ago, and her CAT scan came through, and it's back again. And it's better than it was the very first time, but it kind of looks like the second one.
yeah.
And so, like, what you're getting at now is like, what do I do for her now? And I think it really comes down to I probably have to move her stoma because I've tried this now in 3 places, and it's time to move it to a new location and mesh up everything. But she's gonna be layers and layers of mesh by the time I get done with her, you know. And she's doing fine with them, but it's hard because they do come back and we don't have any good answers for it other than reversing the stoma. If you can get rid of the stoma, that's the best way to take care of this
So
problem.
I have a question for you because you do a lot of foregut surgery. So I assume you do hiatal hernia repairs.
Yep.
Hiatal hernia is conceptually similar to a peristomal hernia, right?
And my recurrence rates are the worst.
Oh no.
Oh yeah, I mean that's another thing is
Like
we
what can
haven't
we learn from hiatal hernia repairs to then make a peristomal hernia repair? Because just for the audience, hiatal hernia is a hernia where the esophagus and the stomach join, right?
yeah,
There's a hole there. It has to be because that's the way you swallow down. Same way there's always a hole where you put your stoma, where you have to make a hole through the muscle to bring up the intestine. Um, so if you're
I
re
don't
like, are you able to take what you learned from hiatal her years and years of doing hiatal hernia repairs can you do a wrap or something? I mean, has anyone
The
thought of
wrap, yeah, the wrap does. So I have actually tried that for a peristomal. I did a pre-peritoneal dissection and mesh, and then I had a big flop of like floppy piece of peritoneum, right?
Huh?
And I basically did wrap the stoma with that because I was like trying to try new things that are safe, but maybe it will help. And so far that guy doesn't have a new stoma, a new hernia, but we had a different complication. He had a perforated diverticulum
Oh,
right after the repair, so we had other complications from him. But you know, with hiatal hernias, it's a similar problem because you have a hole in the diaphragm that you can't close, and I have a similar conversation with my patients for that because the diaphragm is stretchy. It ages as we age, it gets dilated, and so actually the recurrence rates of para esophageal or hiatal hernias is 30%. It's very similar to the
wow.
peristomals. And we've tried mesh, but we have a harder time up there because you can't use a permanent mesh against the esophagus.
It can erode, right?
Yeah. It's just they're both kind of losing games and the wraps don't prevent recurrence. Like that there was some data a while ago that showed that they might, but there's been plenty of data that doesn't. One of the things recently that's been shown to reduce the risk of recurrence in hiatal hernias is a gastropexy when you sew the stomach up to the diaphragm or to the abdominal wall.
Okay.
And that's something I've tried with peristomals to tack this, the stoma
Yeah.
up against the wall
Mhm.
laterally too, and try and keep it down. But I don't know that that actually helps
They
either.
do that for like J tubes, right?
Yeah.
Tack like a long strip of the jejunum, for example, for jejunostomy feeding tube,
Oh, yeah, there's a,
right? There's like a little some length of it that sometimes they tack up to the abdominal wall.
yeah, yeah,
But I mean, a sugar baker repair um, kind of forces the intestine to lay in a certain way against the
yeah.
abdominal wall. It just doesn't force it to be that direction.
Yeah, and the problem with the sugar baker is there's still an opening between the mesh and the abdominal wall where your
Yeah,
bowel goes through, right?
yeah,
And the recurrences I get after sugar bakers are through that. As
uh,
it dilates, the small bowel usually will herniate kind of along that bowel and over the mesh. Uh,
yeah.
so yeah, I mean
Yeah, I teach that. That's like the Goldilocks situation where you can't make it too tight and you can't make
yeah,
it too loose, and it's just never perfect.
yeah,
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 I understand.
yeah.
Yeah, that's a tough one. Um, I wonder if, and then tell me a little bit about, because another question that was posed was the use of just prophylactically preventing a hernia. What's the status of that?
For peristomal hernias, there's actually really good data to say that we should be putting mesh in for prophylaxis.
Yeah.
It's in a synthetic mesh, so a piece of plastic basically. Really, in any layer that you have access to, it is better than nothing as far as reducing the risk of getting hernias.
Hmm.
It's something that I struggle with because the data tells us we should be doing it, but people don't do it. And it's been very hard to get surgeons to adapt or adopt that technology. Uh,
Hmm.
it's similar in aortic patients that have big aortic surgeries. They're very high risk for hernias along their incision. And a lot of times those are side hernias, right?
Yes.
And there's good data, like very good data to say that we should be putting mesh in those patients when they're having their primary
Yes.
surgery. And we're not doing that either. And I think because there's so much mixed bag about mesh and the potential for complications and the downside that people are afraid to use it when they don't have a true hernia to fix
Yeah.
and not to see it as a real way that where it's safe to actually prevent hernias and that you're probably saving the patient a lot more by doing that than waiting until they get a hernia to put a mesh in.
Yeah, it's probably one of those situations where if you put in prophylactic mesh and a larger majority of your patients do well, no one congratulates you. But if you have a
Right.
patient that has a mesh infection or fistula or something like that, then
Yeah.
and they're like, "What? You're using mesh and that has so many complications?" And yeah,
And
like,
that's that M&M conversation, right? Like
yeah,
you shouldn't be doing that. You see this as
yeah,
wrong. You're like, no, I have 99 that did great. And the one that gets presented, is it had a problem. But
yeah.
I do think that's part of it. Yeah.
Yeah, and then what about flank hernias? Well, I used to do even more until I started educating the spine approach surgeons about how to handle these flank incisions. And I
Mhm.
started giving talks to urologists about how to like reduce how many flank incisions they make. Um, but the flank hernias are also a problem. Those are these kind of hernias to the side. Um, do you see a lot of those?
Yeah, I see my share of them for
Yeah,
sure. They're definitely not the highest volume just because they're just not as frequent. But I
yeah.
see them after kidney transplants, I see them after spine surgery, I see them after aortic surgery, and I see them after some orthopedic procedures at the pelvis where they like to take the part of the pelvic bone. There's
Oh, yeah, those are difficult.
yeah, and
You
so
gotta
you're
plate those. You can't just use mesh. You have to use a plate. It's so interesting.
yeah.
You have to redo their anatomy like it was before.
Yeah, yeah. So definitely we see those. I think there are fewer because of the robotic surgery, actually. I think so much, like a lot of urology has converted to robotics, and so
Yeah,
they're not making big side, incisions as much anymore. And so
yeah,
I do think that has helped. And I think educating surgeons on how to close the abdominal wall helps a lot too. And so I've done some of that as well to try and help prevent them because if you can get a good closure and avoid a hernia, then again, whether you have to put mesh in or not, that's better for the patient.
yeah. I remember the XLIF where like
Oh, I just lost your audio again.
mind of its own. This
Yeah.
But the XLIF, which is the trans-psoas kind of lateral um, intercostal, or basically the fusion of the spine from the lateral approach
Hmm.
side, became really popular, and we got tons of spine surgeons
Hmm.
around where I work. And I was getting hernia after hernia after hernia. And most of these surgeons were telling their patients, oh, it's just some swelling, oh, it's a seroma. But then 3 months later, it's still bulging. Um, and I figured out that there's like a sentinel paper that described how to do this operation.
Uh,
You can do a much better, let me rephrase this, a lower risk operation going trans-psoas from the side than trans-abdominal. So spine surgeons, let's do it this way.
yeah.
And I read the paper, and in the paper, it described closing the external oblique muscle with
Hmm.
mitral suture. And I'm thinking, okay, this totally explains what's going on because number one, there's 3 layers of muscle there. They're only closing one
Hmm.
layer. When I see them, they often are misdiagnosed as not having a hernia because technically one layer is still closed.
Yeah.
So 2 layers that have given away, and it gives you this relative bulge. Vicryl is not good enough because 3 weeks later it's pretty much non-functional suture.
Yeah.
You're dealing with these very thinned out flank muscles on the side, whereas the rectus muscle in the front is like bulkier, and the fascia of that is even bulkier. So,
Hmm.
and then lastly, all these patients are constipated, so they're
Yeah.
draining
They're
along
on
one side
narcotics.
is full,
Yeah.
right? So it's like a bad combination of like bad tissue, bad suture, constipated. Um, so I started giving talks. I'm like, guys, I understand that's how the paper wrote it, but this is a spine doctor that wrote the paper. Let me tell you, as a hernia surgeon, don't use Vicryl, use like PDS, which lasts longer. Or even Prolene if you want permanent, but don't use something that's like so rapidly absorbable.
Yeah.
Please take all 3 layers in consideration when you close instead of the one layer. It's more difficult, but that's what you have to do. And we published the largest
Serious.
series of patients like this. But you know what? My numbers went really far down because they started listening and they changed.
Hmm.
We haven't had a single hernia ever since we changed. So I thought, okay, this is a good learning experience. Let me submit a publication to the spine journals. There's 2 main spine journals. They both rejected, saying this is a hernia issue, it's not a spine issue. And I'm like, are you serious? We're trying to prevent the hernias. And then I submitted to what did I submit to? I think I submitted to a hernia journal, and they said this is a spine issue, not a hernia.
Yeah.
So I finally like had to submit it to like a just a general surgery journal. But
Yeah.
it's so crazy that
Yeah.
we just don't think. We don't think about what we're doing and understanding that the side is so different than
Yeah. The consequences. Yeah.
what do you think about incisions, even trocars? Like if you put a robotic trocar through the rect like outside of the rectus, that's
Yeah.
prone to hernias. Is there any?
Yeah, I've made my share of those because I do a good amount of robotic surgery too, and I like to use the longer ports to help bring the robot away from the patient when I'm doing big ventrals. And I've
Yeah.
definitely found that because of that, it changes the torque. And then a lot of those patients have very thin, lateral muscles. And
Yes.
I've started closing those port sites because I had created
Yes.
a series of flank hernias by doing that. But yeah, it's hard, especially in the aging population. The,
Yeah.
they just don't have the bulkiness in those muscles, and
Yeah.
so it's a straight shot. And sometimes you put a port in, you can actually just look right through it. Like there's
Yeah,
no
you're staring at the hole right through the skin.
yeah,
Yeah.
right through the skin into the abdomen, and so those are hard. I think, and all of those, if people don't understand the anatomy with the three muscles, I see a
Yeah.
lot of the, oh, it's not a real hernia, like you're
Yeah.
saying, but
Yeah.
2 out of the 3 are quite wide and then stretched, and then the external oblique that's still there is atrophied and completely atonic because it just has been stretched and stretched and stretched, and it's like a
Yeah.
thin balloon. And those are hard to fix because you have to figure out what to do with that thinned out external muscle and then try and stretch these contracted internal and transversus muscles back up to meet where they're supposed to go. Um, but they are satisfying, and despite not being able to make people like symmetrical again, that's always what I tell them is, you're never going to be the same as you were before. You'll always have some asymmetry, but
Yeah.
at least we can get everything back together again and reinforce it with some mesh and make you feel stronger.
Yeah.
And that to me is the important part because I really think the core is like a cylinder, and a cylinder that has damage to it loses all of its strength. Like we use cylinders for rockets and in our shuttle and our airplanes because it's a very strong geometric shape. But as
Yeah.
soon as there's damage to the structure, it loses that strength. And I think the core works functionally like that. It's a cylinder with a roof and a bottom. And when you've got damage, all of the support to your spine and your midline, the front part of your abdomen goes away. And that's when you start having back pain and hip pain and problems walking. And so just making those hernia repairs, even though they may not be perfect, will make people more functional, and it
Yeah.
helps their constipation, it helps their urinary symptoms, it helps their pelvic floor, it helps their breathing. And I might not be saving their life, but I'm definitely making them better, right, by doing those troublesome hernias.
Yeah, it's something that, patients will never really ask their surgeon about this, but then the surgeon, it's incumbent on the surgeon to understand the anatomy and be cognizant of where they can place incisions, where they're least likely to cause hernias. Um,
Yeah.
as hernia surgeons, we think about that. But, if I were let's say a acute care surgeon, right, someone who just takes care of patients that are really sick and ill, I may not be that cognizant of the fact that placing any incision or even a trocar site from a laparoscopic or robotic surgery on the sides would cause pain. I think the issue with robotics is you have to, because of the torque that's implied, you have to go perpendicular.
Mhm.
Whereas for laparoscopic or like assist ports, you
Yeah.
like if I put any on the side, I really skive it. So if
Yeah.
you're skiving it, you're not making like
A
circle
straight hole.
straight
Yeah.
holes. It's less likely to get a hernia.
Yeah. Yeah. Because then you have the overlap of the muscle
Yeah.
layer you're skiving through. Yeah,
Do you
that's
know if do you know if there are situations where let's say you're only working in one direction, like only in the pelvis, maybe it would be safe to skive the robotic trocars?
Oh, I would think it would be if you had
Yeah.
a simple, like it could be something we could try with hiatals, but
Yeah.
I don't get hernias after my robotic hiatals, which is funny because I put 5 ports
Or
in.
five.
One of them is a five, just a laparoscopic 5 port for the liver retractor. And,
Yes.
and I put one on each side and then kind of two in the middle. But I actually have never seen a port site hernia after a hiatal hernia. It's only after ventral hernias. So
Huh.
and I think that probably is that the torque and the
Or
direction because
yeah.
we're working up to, towards the head with the hiatal rather than lateral in those
Yeah, there's
weaker.
much more movement in
Yeah.
multiple directions with the abdominal wall one. I would say
Yeah.
angle probably is also fine because it's
Yeah.
always so if you're like looking straight into the pelvis or straight up to the chest, then maybe we can, if you need to put a lateral one, you can kind of skive it.
Yeah. Yeah, and when I think about it, the way we put our ports in on the lateral side for the hiatals, I do kind of skive them because I aim them up towards the hiatus
Yeah.
anyway. So yeah, and I know I hadn't really thought about that before, but it's true. I have not seen a port site hernia from a hiatal hernia repair yet.
Huh.
Yeah.
Um, okay, let me share screen here. One of the questions that we had, we already answered, which was why don't surgeons just use mesh for the stomas? The risk seems low and the benefits are high. Um, are there people that are using the fully absorbable meshes for peristomals?
Yeah, for peristomals, and I think for make when they make the
When they
stoma
make it.
originally,
Yeah.
I I do think yes. I think people still are using biologics that are
Yeah.
fully absorbable. People are using some of the newer biosynthetics that last a little bit longer. Uh,
Mm,
and I think that data is remaining to be seen. I don't have any good data behind that yet. Uh,
right.
and then people, if some people will use just a permanent mesh as well. From my experience, fully absorbable meshes for peristomal hernias just have almost 100% recurrence rate. You need that
Oh,
structure.
yeah.
The and
What about the
even
hybrid meshes? They have a little bit of synthetic woven into them.
Yeah, I actually haven't. I don't know that I've had any experience with those for peristomals.
Would make
Um,
sense.
But it's definitely an interesting idea to give a little bit of structure left, to have a little structure left behind even when the absorbable
Yeah.
portion is gone.
Yeah.
Uh, and I know also recently the mesh suture that's come out on the market, people have been
Yes.
using it for peristomals and trying different things, whether it's like a purse string where you make a circle around the stoma with it to see
Okay.
if you can get that from dilating or just closing the defect with it. But I've heard mixed reports on outcomes for that, and I don't think it's actually been on the market long enough to know what the recurrence or complication rates are
I
going to be.
just, do you just take the mesh suture? So mesh suture, it's a cute idea. It's like a it's a little bit more inflammatory suture, I should say. And therefore the thought is it's a little bit bulkier, but a little bit more inflammatory, and therefore it causes more scarring and hopefully therefore less hernias. I think that's how it works, right?
Yeah, well, so it's actually a proline mesh, basically, that's just rolled into a roll and then
Yeah.
attached to a needle. And so the idea of it is that it just gives you more area to grow into because
Yeah.
you have not just one small suture, but kind of a bunch of sutures that are interwoven. And
Hmm.
and so the idea is that there's more kind of scaffolding for the body to scar into
Yeah.
the way we think of mesh. It will be interesting to see because I've used it and I think it's a great idea for some things, but when you sew with it, it all gets bunched up. So then you just end up kind of with a big bunch of, suture. And
Yeah.
I know some people have been posting, people have used it on a hiatus and still get recurrences for hiatal hernias. And going back in there, it's really kind of just a mess of scar tissue to deal
Yeah.
with. And so with the peristomals, I've heard people, I've used it to close the defect, to tighten the hole up around the
Okay.
stoma, and then also reinforced with a mesh, just as kind of one more added thing to try and help. Other people are using it and sewing in a circle around the stoma and kind of tightening it up like a purse string to see if they can make it so it
Oh.
won't dilate with
So do
because
they take the muscle and then they just kind of sew the edges
like if
like
you're
you would at
making
the edge
a
of a shirt, like a collar or something?
So
Kind of,
if you wanted to take a collar but pull it tight like a drawstring,
yeah.
right? And so you're sewing around that circle, but then you're pulling that tight so you're squeezing it up and
Got
in.
it. Got it. Got it.
Yeah.
Okay.
Yeah.
Yeah, it's worth it.
Um,
Yeah.
yeah, but I mean, there's not good data or outcomes yet to know whether
Yeah.
that is helping or not. Yeah.
Next question. What do you think of we already talked about it. What do you think of the absorbable meshes for peristomal hernia? So that's for a definitive hernia repair, it's out, right?
Yeah.
Absorbable mesh is not considered a good option. Um, and for preventative, is it still out?
No, I think it's a reasonable place to use a long-lasting absorbable mesh
Yeah.
in um in the like a primary if you're making the stoma and putting a mesh in as a preventive measure.
Mm-hmm. Mm-hmm.
Those those absorbable meshes definitely leave some scarring behind, which potentially could help prevent hernias in the
Hmm.
future. I don't like the data shows that synthetic fully permanent meshes is are safe and the most effective. So I don't think absorbable meshes are out, and I think it's a reasonable thing to try and that we should study those outcomes. But in comparisons, the synthetics are as safe, and so the permanent ones are as safe, and so I don't see a benefit to
Got it.
using
Yeah.
absorbable ones. Plus,
Got it.
they're more expensive, so you're adding cost and then
Yeah.
not really adding benefit.
Yeah, I agree with you. I completely agree with you. Okay, next question. If I have a side hernia, can I ask for no mesh repair?
You can always ask for no mesh repair. Um, the conversation I would have with you is that it really kind of depends on where and why you have a hernia.
Uh,
And because there are certain places where I know if I just sew it back together, it's coming back. Like, especially where, the anatomy of the abdomen, a lot of those side hernias happen in between the six pack muscles and the side muscles. There's just
yeah,
thin fascia there. And
yeah.
I'm pretty sure that if I were to just sew those together with a suture that goes away, that hernia is just coming back because there's no muscle, there's nothing to structure or scar in. But there are other places where maybe it's a hernia where you have a couple muscle layers and that are still there and strong that we could potentially try it. But I would warn people away from no mesh on side hernias because I really think that's a place where you need some structural like support for the scar tissue to grow in
Yeah,
because it's just
I
so
agree. It's
different.
really hard. There's very thin fascia laterally in the midline, around the midline. It's nice thick fascia at least. And even
Yeah,
those, the non-mesh repairs have a pretty good size failure rate. It's even
yeah,
worse when you go further laterally.
yeah.
Um, Question for you. So, do you think these side hernias are best done open or laparoscopic or robotic?
I think it depends. I do them both ways. Yeah.
Yeah.
I I really think that I can, well, laparoscopic or robotic can be very beneficial for some of them because I can basically peel down the inside layer of the abdomen and then all the way down to the retroperitoneum, so to the fat behind the
Yeah.
kidney, create a lot of space there. And then I can sew the muscles back together and put a big mesh and cover that up with that layer. And
Hmm.
I can do that both laparoscopic or robotically, depending on how big it is. If it's big and bad, then I'll use the surgical robot. But for Spigelian hernias, which is a side hernia, right? I love that as a laparoscopic case, and there are some others that are work for that. But there are definitely times when an open side hernia is the way to go. If you've got big floppy external oblique and then a big hole and you need to be able to kind of plicate muscle and put it
Right.
together in the right layers, then that's better approach. If they're really big and you have loss of domain through there, you probably need to do it open.
Yeah.
And then the other time I will go for open is if there's excess skin or stretched out skin that needs to
Right.
come off, because you get a much more cosmetic and I think functional repair too if you take that skin at the same time and
Yeah.
kind of tuck everything back into the right proportions.
Yeah, going back to what you said earlier about, the in your fellowship where you had like the foregut surgeons doing everything minimally invasively and the hernia surgeons ending up doing so much maximally invasively. I feel that over time, as you become more experienced with hernia surgery, you move away from laparoscopic robotic surgery a little bit because you understand that there is a role for open surgery. Whereas, maybe early on you're like, I want to do everything laparoscopically and, it's like the way to go. But then with experience, you understand there are benefits to doing something open, whether it's cosmetically, getting a better repair or skin issues, and so on. So, yeah, I totally hear that in what you're saying, which is, uh, it's not always better laparoscopic or robotically.
Yeah. I think, yeah, I'm definitely one. I don't have huge robot numbers. Like, some people will be like, I've done thousands and thousands of robotic
Yeah.
cases because I choose to use it for very specific things.
Yes.
And so I use it for my revisional surgery for foregut, and the rest I'll do laparoscopic. And I use it for complex hernias that I feel are appropriate, but I don't think
Yeah.
everything is appropriate.
Yeah.
And it's funny, when I was a fellow, we actually, that was the year we did the first robotic TAR. Like we were growing that year,
Uh-huh.
and learning it, and it was becoming popular. So it's been funny. It's been interesting to watch it like explode and
Yes.
cause problems, but then now also kind of like slowly, like you're saying, like
Yeah.
people are
Yeah.
learning from that going away. But I also do paniculectomies because
Yeah.
and I was just looking, I did one today, which is getting rid of excess skin in patients, mostly after weight loss. Is our We have in Maine, something like 60% of people are on Medicaid or Maine care.
Yes.
It's a very large number.
That
And
was a big deal with your recent like political campaigns. Yeah.
yeah, yeah. And the plastic surgeons in the state won't, most of them won't see patients who are on Medicaid, and so they don't have any access for this. So it's become kind of my one of my little niches, and our bariatric patients will come to me, and I'll do them, and so I enjoy them. So I also enjoyed that part of the open hernia surgery as well, is the plastic surgery part of it, where I get to make it look
Fun.
real nice at
Yeah.
the end, right?
Yeah.
And you reduce the risk of seromas or fluid collections by getting rid of the excess skin, and you're reducing the risk of wound infection by getting rid of old, scarred tissue. So I think there's a lot of benefit to open surgery. And
Mm.
I think I also say like an open lysis of adhesions is like my like Zen. Like that's where I find my flow state, which is
Yeah,
interesting.
I agree. I
It
agree.
it's not I like a robotic lysis of adhesions too, but it's not the same. And
No, no, no.
yeah.
It's like kneading bread versus putting it in a like a bread machine.
But
Like you want to do that part is you I agree with you. It is very zen.
yeah, yeah.
Yeah. And then what's your experience with these nerve injury abdominal wall kind of where the side really pooches out? Have you seen
Yeah.
those?
I've seen those. I think about other people ask me too, like, do you repair them? And I talk to patients about it, and
Yeah.
it really depends. And I've done some research, or like read some of the research about it too. And there are some case series that show good benefit from a pain or a functional standpoint of
Yeah.
basically like plicating the muscle, so kind of scrunching it up and sewing it back, tightening it up for people. But I actually personally haven't done it. Like when I've talked to patients about it, I see it, I explain the problem, and then I send them for physical therapy first because that would be my
Yeah.
first line treatment. And either they don't come back or we just decide not to go forward with surgery. I always have concerns about causing worsening chronic pain by
Yeah.
doing it because
Yeah.
of the muscles and the nerve structures that go through there, and then you're like scrunching them up and sewing them into suture. And so it's something I think is an interesting idea, but
Yeah.
I will plicate those muscles if I'm fixing a hernia. There's a hole, but then there's also stretched out muscles. I'll tighten them up to give it natural or like tension,
Yes.
but I've not done it really without a true hernia.
Yeah, going back again to like vascular surgeons who like resect a rib, to try and gain access, whether it's for thoracic surgery or like spine surgery or for aortic surgery,
Yeah.
uh, and also spine surgery. So I have my fair share of patients that have this, what we call eventration. It's like a laxity of the muscle. It's very deforming looking, and
Yeah.
the muscle just doesn't get good nutrition from the nerve, right? So it starts loosening up, and you get this asymmetry where you're like an alien's coming out from your side,
Yeah.
and there's no good way to make it go back because the nerve is injured, um, like directly transected or stretched out or something like that. So I did my first one, I'm gonna say like maybe 20 years ago,
Hmm.
where I collaborated with a plastic surgeon. He seemed to kind of be like, oh, it's just like a tummy tuck. We'll just do a tummy tuck on that side. And um, I learned from him that just plicating alone is not enough. You have to like really plicate it, like tighten that muscle really more than you're comfortable doing as a general surgeon.
Yeah.
Um, and then, of course, the muscles are not healthy, and they're, as we discussed, they're kind of thin on that side. So then you put a really wide piece of mesh to cover that whole area, but you have to basically wrap the patient with mesh.
Mesh.
Um,
Yeah.
and you have to sew the mesh to bones, so to the pubic bone, inguinal ligament, pubis, ribs, around the back, across the midline. And for the smaller ones, it works pretty good. Works pretty good. You have to be, I also sew the mesh to the suture line.
Hmm.
For the bigger ones, I feel like the muscle just still gives way.
Yeah.
And maybe the area where you sew it to the bones holds, but in the front, it still just gives way because all you're attached to is like the other muscles.
Yeah.
And it probably helps them in that if you didn't do it, it will just continue to grow and just become very heavy and painful. But I tell my patients, this is the worst operation I offer in terms of
Hmm.
outcomes. Like it's the least likely to be perfect. It's a big scar, it's a lot of mesh. Um, and I don't know. I don't think we figured out the best way. I've seen people that have offered robotic plication, and I think that doesn't work at all because you need to make it super tight, and you can't make it super tight robotically because you just don't have the space,
Yeah.
right? And you just can't put enough mesh to wrap it around. You're just basically treating it like a hernia, but it's not.
Yeah.
So I think robotic is a wrong decision, but I don't know how you feel about that.
I mean, I think that it still is remains to be seen because
Yeah.
I do think as we've gotten better with the robot, like I can do such a massive dissection with it and really
Yeah.
open up the same kind of space and get all the way back to the spine and up on the diaphragm and down to the psoas. But I think that where like you're saying the tightening of it, you're working under tension and
Yeah.
because you've got the patient insufflated.
Yeah.
And I always decrease my insufflation, so I decrease the pressure that I'm working when I'm closing
Yeah.
hernias. But you have to have enough space to work in, so you
Yeah.
have to have some, and then you're working in a place that already it has tension. So when you if you can have them paralyzed I mean they're paralyzed for robotic surgery, but they've stretched out, but like
Yeah.
paralyzed and truly relaxed with an open repair. So, and maybe that's a place for hybrid. Like if we can do the dissection and place a big mesh robotically without having to do that giant
Mhm,
but
mhm.
then somehow maybe do the plication open.
Yeah. Yeah.
Then, I think there's probably still some innovation that can be had there. I've tried to send some of those patients to physiotherapists for like EMG therapy and
Uh-huh,
stuff,
uh-huh.
and I have had no luck. They
Yeah,
always
it doesn't work. Physical
we don't do
therapy, EMS. Well, there's in LA. EMS is really like caught on where they put these suits on you and it just kind of
oh
uh they're like, oh, you can do 1,000 sit-ups worth of exercise in
oh
just
yeah.
minutes. Um, so I've asked those people to see if that will help like regenerate some muscle or something, but so
Yeah.
far, I mean, it's worth studying, but that doesn't work.
Yeah.
Yeah. I have a inguinal hernia question that's being posed, if I can read it to you.
Yeah.
It says, despite inguinal hernia surgery guidelines, it seems to me that even now there are still many publications that either combine the information from prior studies, like a meta-analysis, or studies that look at previously operated patients from one or more hospitals retrospectively regarding how best to reduce pain following surgery. Some of the comparisons are the type of surgery, like open tissue, open mesh, shoulder, slap, and others. Um, Other comparisons include mesh weight, pore size, whether the mesh needs to be fixated, how the mesh is fixated, And it seems to me sometimes articles don't necessarily reach the same conclusion. So given that, how do you decide what and how you perform your repairs?
Okay. Um, so I think that chronic pain after inguinal hernia comes down to technique. So that's
Mm.
why I think the data is,
Technique or decision making or both?
well, I think
Like
it's
is technique part of the decision?
yeah, and the
Yeah,
technique is
okay.
part of the decision,
Yeah.
but I think it's being aware of your anatomy, knowing where your nerves are,
Yes.
and how to avoid them, not over dissecting,
Yeah.
and not putting mesh directly on nerves, and so
Yeah.
I think it's really technique and decision making, which I think is why that the data is so confusing because there are studies that tell you that heavier weight mesh causes more pain, and then there's newer studies that tell you that it doesn't matter if it's
Yeah.
midweight or heavyweight.
Yeah.
It doesn't matter
Crazy.
if it's open or lap, it doesn't matter. And I think one of the things that's been consistent is if you use more than 10 tacks, you're higher risk,
Yes, that's the
right?
Hennepin paper. Yeah. Yeah.
Yeah, because I think no one's actually looked at it again, probably because we don't use tacks that much. So I think it really comes down to technique. So that the decision on how to fix an inguinal hernia for me is a shared decision discussion with
Yeah.
the patient.
Hmm.
And I do more laparoscopic than I do open, but I do plenty of open inguinal hernia repairs too.
Yes. Hmm.
And I think a lot of the reason I do more laparoscopic is because if they have bilaterals, I prefer a laparoscopic for bilateral because
Yeah.
it's same incision, a little more surgery.
Hmm.
And the data and my experience has been that people get back to activity faster. People play
Sure.
tennis and golf and fishing or lobstering as they do here within 2 weeks of a inguinal hernia repair laparoscopically. If it's a unilateral, so just on one side hernia, then I will often tell them I don't know that there's a benefit to laparoscopy. And one of the great benefits, and I think you and Dr. Blake talked about this last week too, of an open repairs, I can do it under local anesthesia. You
Yeah.
don't to have even MAC, right? You don't have to have sedation. And some people really like that idea. And so I really have a discussion with the patient of these are the options. And this is maybe my recommendation, or this is what I do more frequently in your case, but we'll come to a decision together on how to do that. And
Yeah.
granted, we don't always get to know what happens to our patients, but I can think of two or three inguinal hernia repair patients I've had that have had chronic pain after their repair.
Yeah.
And it's all of them have resolved. But in two out of those three cases, when I did their surgery, they had some sort of acute inflammatory event going on. So
Yeah.
one of them, it was an older gentleman who came and he had a kidney stone, and it had happened like the week before. He was still
Ah,
in pain for it. But he desperately wanted his inguinal hernia repair. And so we talked about it in pre-op, and I was like, I don't think this is a good idea. And he was like, I want to do it anyways. And so I did it. And we
um,
both suffered for it because he was in my office for 6 months with very severe chronic pain that eventually did, like it slowly started to get better and better
yes.
to
Yeah.
go. And then I have another one, and I can't remember what the exact problem was, but it was like an acute thing had happened right before the hernia repair.
Totally
And
get it. Yeah.
yeah. So I think that's the other piece of it is if there's something about the patient that where there's an acute inflammatory event going on,
Mhm.
that chronic pain piece just is much easier to come to
Yeah.
because you're already highly excited, right? The nerves are excited, the immune system is excited. And so that's a lesson that I've learned. I mean, I tried to avoid those situations, but kind of forced into them. But I will be more strict about that when I talk to patients
Yeah.
because
Got
of that
it.
experience. Yeah.
Quick question. As a follow-up, does bilateral laparoscopic hernia repair versus repairing only one side in a patient that only has symptoms on one side, does that double the risk of chronic pain? My patients actually asked that. Like,
Yeah.
am I doubling my risk of chronic pain if you're fixing both hernias, even though I only have pain on one side? What's your practice? Do you offer that?
I offer,
Yeah.
I do it based on that's another shared decision making,
Yes.
right? Like I tell them we can or we don't have to. And
Yes.
I think, I think more often than not, patients will choose to have the bilateral done because
Yeah.
they don't want to, the idea of having another surgery later on is worse than the idea of a potential complication
Yeah.
from that side. But I definitely have other people that say, no, just do the one that's bothering me. And if the other one starts, I'll come back and do it there. And I'm open to that. Whereas my partner will fix the bilateral all the time. It's just
Hmm.
practice. So
Yeah.
yeah.
Uh, if you yourself had bilateral hernias on imaging, but only one side hurt, what would you do?
I would probably have both done.
Really?
But I would also be in a surgeon's office who I really trusted,
Sure.
number one.
I
And
would not. I would probably be like, don't fix the side that doesn't bother me. And so,
I know I'm very active. I lift heavy. I like run it. I go to the mountains. I do things where like the idea of having a potential like complication from a hernia that could be
mm,
prevented to me would push me into that because at some point I'll be skiing across Antarctica. I don't need to have a hernia.
I love it. Okay, so you have to explain to me because you got some pretty cool Instagram
Hmm.
profile. Tell me a little bit more about your non-surgical self. What's,
Yeah,
yeah,
yeah.
explain the name of your Instagram page.
So the Instagram that you put up there is Shutter and Scalpel, and that actually I started that I think as a resident. It's old, but Shutter is for like photography, and then Scalpel obviously for surgery. And when I started that, I had this idea of I my dream job is to be a photojournalist for National Geographic. That's
Wow.
my dream job. Like going into deep, crazy places and taking beautiful pictures and telling stories about the world, right? So
Yeah,
I think I had a dream that I would be able to do some of that and be a surgeon. And I try a little bit. I'm not a
friends that do that.
photojournalist,
Yeah,
but
they're
yeah,
not National Geographic, but they do a lot of photography on their spare
yeah,
time. Yeah.
yeah. So that's that. And then I have another Instagram called Buzzing Wanderlust, which is my travel business. So I'm a travel agent or a travel advisor, and I have a travel business. So I can plan trips
What?
and book your next vacation for
Can
you.
you help me with Africa next year?
Oh yeah. And Africa is like a place in my heart because I live there in the Peace Corps and I travel almost every year. I'm going to
Oh
Uganda
my God.
in October.
All
So
right, I owe you a phone call. Well, are you going
yeah,
to be in Denver at the
yeah,
American
I'll be there. I'm
Society?
leaving tomorrow. Yeah.
Okay.
Yeah, yeah, we can talk
Thursday,
about
I'll
it.
see you there.
Okay. Yeah.
Okay, well, this has been great. I really appreciate your time. You've been awesome. I'm really looking forward to seeing you in Denver at the
Yeah.
American Hernia Society meeting later this week. And I will have to be calling you for my Africa
Yes.
trip next year.
I'll bring you a card so you'll have it.
Oh,
Yeah. Yeah.
I love it. I love
Yeah.
it. Okay, everyone, thanks very much for joining us. This was yet another wonderful um, guest with us on Hernia Talk Live. Our almost we're becoming bi-weekly Q&A. It used to be weekly for like 5, 6 years. Um, don't forget, if you go on YouTube at Hernia Doc, this and all prior episodes are archived there. You can watch it, share it, like it, subscribe, whatever you like to do. And please follow us on Facebook, Instagram, and X at Hernia Doc and Dr. Towfigh. I will see you hopefully next week. See you all. Thank you so much.
Thank you.
Thanks again. Have a great
Bye,
rest
Sharon.
of the day.
See
Bye.
you in a couple days.
Yes. Bye-bye.
Yeah.
Bye.
Bye.